Right, so in terms of this session, obviously the aims of the session, Rachel, if we could have slide 2, that'd be fantastic, are to enable improved identification of the symptoms that could indicate that someone may be developing dementia or have dementia, and thinking about the screening tools that you might be able to use in clinical practice, and then to think about opportunities that we can identify to ensure that people get a timely diagnosis. So really making every contact count, because I think historically what's happened is, we wait for people to present and actually we perhaps don't ask the right questions in an opportune way to be able to enable them to have the assessment, not only to see if they have dementia, but also to rule out differential diagnosis. So we're going to start off with a bit of background. If we could have slide 3, please, Rachel. Dementia prevalence. So it's increasing exponentially. We know from the research that the numbers are growing because we have an aging population. And a research study by London School of Economics estimated that in 2020, there were over 900,000 people living with dementia in the UK. Of course, we have to think about the impact of COVID and the data there, but this is the latest data that we have at the moment that's concurrent. And that's expected to rise to over 1.5 million by 2040, which in the grand scheme of things is not that far away. And I think it's an important factor in terms of thinking about the wider impact to health and social care, in thinking about how we plan care for the future. But of course, the first step is to get that diagnosis. Dementia is not just the disease of older age. And I think often it's forgotten about the fact that there are over 40,000 people living with dementia under the age of 65. And whilst it might not be that common, I think it's probably something that most of us who work in dementia care would think is probably an underrepresented figure. And there are probably people who have been misdiagnosed with other conditions when actually they may be experiencing young onset dementia. We go to the next one, please, Rachel. So one of the issues that we have is I think dementia is homeless, effectively. When we look at the systems and our services, dementia is often seen as a mental health condition. And part of that is historically the bulk of memory assessments have been done in mental health services where there's been the expertise to do that. But dementia is not a mental health condition in its traditional form. It is a neurodegenerative condition for which there is no cure, and it's life-limiting. And I think this is where we've got a bit of an issue in terms of how services are developed, because it's seen as a mental health problem. It's, by some still, it's considered that mental health services are delivering all dementia support, when in reality, most of it is done within generalist services, whether that be health or social care. The other thing to consider is that we tend to set up singular services. So we have situations where someone might be seen for dementia, for example, but they might also be living with other comorbid conditions. And we don't look at those things in totality, we look at them in isolation within systems. So you might see someone for heart failure, you might see someone for COPD, you might see someone for dementia. But all of those things can interact with each other. And actually understanding how those interactions happen can be really important in enabling people to live as well as they possibly can with all of their conditions. And also to set reasonable goals and treatment plans for people with dementia and other conditions, because we know that dementia rarely travels alone. Over 90% of people with dementia have at least one other comorbid condition. And for people that are much older, so in their 80s plus, they can have 3, 4, 5 plus comorbid conditions. So these are people with really complex needs. And I think often, myself included as a mental health nurse, I wasn't taught about the wider implications of dementia and the impact and the palliative care needs of someone with dementia. Those are things that I've had to develop and learn as I've developed in my career. We also know that there are other high-risk groups in terms of people with learning disabilities, for example. So people with learning disabilities are far more likely, particularly those with Down syndrome, to develop dementia at a much earlier age. People with Down syndrome are more likely to get Alzheimer's disease, and it tends to manifest itself from mid-30s onwards. So what we try and do is get baseline assessments done at around 30 for those people that we have a known learning disability, so that we can see if there are any changes as they age. And that's quite significant difference in terms of the prevalence if you look at the wider population, where 13% of people with learning disabilities are likely to get dementia within the 60 to 65 year age group, compared to 1% of the general population. So that's quite a significant proportion of people. The other thing we need to consider is care home residents. So we know that there are around 70% of people in care homes who are either have dementia on admission, and that's the reason that they end up going into residential care, or they develop it whilst they are within the residential unit. And what we also know is people in care homes are less likely to get a diagnosis. There's often this misconception that there is no point in the diagnosis because someone is often in quite the advanced stages of disease, whether that be from dementia or other comorbid conditions, and what are the benefits of that. And I think from my perspective, and I'm sure from many of your perspectives, one of the really important things to understand is if it is a neurodegenerative condition, we need to be thinking about people's end of life care. And if we understand what their needs are, both from dementia and other comorbid conditions points of view, we can think about that anticipatory care planning at the end of life, make decisions based on the understanding of what the benefits and risks of certain treatments options are. So I think it's incredibly important. There are lots of reasons why it happens. Some of it is it's almost kind of a bit Chinese whispers. People assume that it's already known, but actually someone's not really had a formal assessment. It might be that there is a high proportion of people that have transferred into residential and nursing care, but beyond an acute hospital admission. And at that point, it's kind of been put query dementia on the notes. And so subsequently, without any formal assessment, it becomes known in the loosest possible terms, but people don't have those assessments as often as they should. So I think from my perspective is that's an area that we really do need to think about. And we'll come back to that later as to what the opportunities might be. If we could go to the next slide, please, Rachel. So when we think about dementia, I don't want to sort of minimize this session, but I think it's really important to kind of think about the language that we use. And still commonly on patients' records, I see this person's got dementia. Well, actually, that means very little, because dementia is an umbrella term for so many different conditions and subtypes of dementia. If I had a patient with an infection or cancer, for example, I wouldn't expect their notes to just say, this person has an infection or this person has a cancer. It would be about, well, what type of infection have they got? What type of cancer have they got? Because if I know what type of condition they have, I might have a better understanding of what their possible symptoms might be, what the treatment options might be, and the type of support they might need to enable to manage those symptoms. So the most common ones you'll see there on the slide are Alzheimer's disease and vascular dementia. Alzheimer's disease is definitely the more prevalent one, with dementia in Lewy bodies and frontotemporal lobe dementia. And a mixed dementia, which is often a combination of Alzheimer's disease and vascular disease, both of vascular dementia presenting at the same time. Now, it is important to understand because these presentations have very different symptomologies, particularly when presenting in the early stages, because there is a propensity to think that, one of the things we see in a lot of general practice areas and things is, are you worried about your memory? If you're worried about your memory, then present to GP. But dementia is much broader than just memory loss. It's about functional ability, it's about communication, it's about being able to plan, all those type of things, as well as memory. And for example, Alzheimer's disease is very slow and insidious in its decline, where vascular dementia can be very, very stepped. So people can kind of plateau, drop, and then plateau again. So the way that it presents is very different. Dementia with Lewy bodies is often, in the early stages, misdiagnosed as either anxiety or depression, because that might be the type of symptoms that people see in those earlier stages. So again, if we were thinking about just memory as being an early identification symptom for dementia, it might be missed. Frontotemporal dementia is often very much manifested with personality changes and behaviour changes in the early stages. So again, it might not just be memory loss. So I think from, you know, I don't want to give you a kind of blow-by-blow account of all the different types of dementia in this session, but I would really urge you to go away and perhaps, if you don't feel confident about understanding the differences within those different diseases, is to have a look and explore them in a little bit more detail. But equally, think about how you write within your notes, and how others write in the notes. If you see dementia, perhaps challenge it and try and drill down a little bit harder, because it may enable you to support someone far more effectively by knowing that. We could have the next slide, please, Rachel. So I came across a lady, interestingly, last week who was 84. She was very concerned that she might be developing dementia because she felt that she wasn't as sharp as she was. She didn't feel that, you know, she was functioning in the way that she used to. And so she presented herself at the GP surgery to ask for a memory assessment. Now, I met her at a social gathering, and I was doing a presentation on dementia, and she said to me that she would like to, if someone was to present at a GP practice and they scored okay on the cognitive assessments, should they be concerned? And I said, no, not at all. We had a very big conversation about it. She'd scored well in a cognitive assessment, but she was still anxious that she might be developing dementia. And we talked about what's normal in typical aging. So, you know, all of us, all our organs, all our functioning slows as we get older. I'm sure some of us feel we're not as sprightly as we were when we get out in the mornings. And things do start to slow down a bit. But that in itself is not dementia. It's, you know, if we are slightly distracted, and we take a little bit longer to kind of react to things or to glean those memories, that may not be an issue in itself. It's when it starts to become more of a wider issue in terms of our cognitive functioning. And if we go on to the next slide, please, we can see that there are significant difference in what's typical aging and what's dementia. I find that I get to the top of the stairs very often and forget why I've gone upstairs. I go into the kitchen and perhaps open the fridge and forget what I've done, you know, or why I've gone to the fridge. You know, those are normal things that happen. And for this lady that I was talking to last week, one of the other big issues for her was she was a lady who was incredibly socially active. So she had an awful lot going on in her world. So a lot of the reasons that she was forgetting things was because she was so busy. And actually, she was juggling a lot of balls and she dropped the odd one. And I think by reassuring someone about what the differences are is just as important as recognizing when they might have dementia, because a lot of older people really fear dementia and are incredibly anxious about it. Some will avoid assessment because they're worried about what they might be told, but for others, they might present with some of these symptoms around typical aging, with a fear that actually they are developing dementia. And screening is only part of that reassurance process and screening process, actually, because for this lady, yes, she'd done the screening test and yes, she'd passed with flying colours, but no one had actually thought to explain to her about what might be happening in terms of her aging brain, and the fact that what she was experiencing was normal. There was nothing to be concerned about. So despite the fact that she'd sought that reassurance, she didn't actually get it. So what I'm saying is, again, it's about understanding how to support people in identifying dementia, but also in perhaps other conditions that they might be experiencing, or fears and anxieties they might have. If we go to the next slide, please, Rachel. So in essence, dementia is more than just memory loss. And I often use the example of thinking to someone, well, if you forget where you put your keys, we all do that. It's not a problem. It's when you put your keys in your hand and you can't remember what they're for that you might want to be concerned. And when we think about dementia, it's, you know, it's not just about that memory. It's about our judgment and our decision making and the impact it has on the relationship that we have with other people. And that might be because of personality changes and abilities to communicate as effectively as we once used to if we develop dementia. And so I think that's when we have to really identify how to do that. And we can do that through the cognitive screening tools, which we'll talk about later. And if you think about your brain as being, different parts, the actual cognitive assessment itself is about looking at different parts of the brain throughout. So people will often say to me, well, why do we draw a clock face, for example? Why do we need to put the times in? Well, that's not about memory. It's about concentration and calculations and being able to put that detail in and manage that in a way that's very different to recording 3 words at the start of the assessment. So all of these elements are there to look at those wider issues of cognition that are not just about memory. We are not talking about testing memory here. We're talking about cognitive assessment, which is much broader and much different. Next slide, please, Rachel. Now, the government set a target back in 2015 about ensuring that we had 2/3 of the population diagnosed with dementia. That would be 2/3 of the people that we anticipate have dementia within the UK. So there's lots of calculations that are done using the data and estimating the prevalence. Now, pre-COVID, in some areas, there was excellent results in this. People were getting beyond 67%. But in some areas, it was still very low and in 30–40%. And there's lots of reasons why that happens. Some of it is about the local services, some about resources, some is about motivation of clinicians to be able to actually diagnose. But as you can imagine, COVID has had a really significant impact on the diagnosis rates for multiple reasons. One of it being, we know that people with dementia have been disproportionately affected by COVID, in fact that, people in care homes, we've lost a lot of people in care homes, many of whom would have dementia. And a lot of people with dementia have had other comorbid conditions and been older, so have been more susceptible to death from COVID. So that's had an impact. But then what's also had an impact is the ability to access memory assessment services, to access GPs practices. So if people were concerned, particularly in the start of COVID, they wouldn't have been presenting because we were kind of in an emergency state effectively. So we were only reacting to crisis, not looking at some of the more preventative work that we could have been doing. Memory assessment services were kind of pulled back into more acute services to manage the situation as they could, best to their ability. And so we've got this kind of lag of people who were perhaps referred for memory assessment prior to COVID and still haven't been seen, or there's been significant delays, but also people who have concerns who've not been able to get a GP appointment and then subsequently haven't been assessed and haven't been referred. So we've got a whole recovery that needs to happen now in terms of supporting those people to get the help and support they need. And I think it's even more vital as we come out of COVID, because a lot of the support mechanisms that would have been there within the community pre-COVID are not in place. A lot of voluntary organisations, a lot of community action groups and support groups that may well have been able to kind of give people a little support at home almost disappeared overnight. And we don't know what's going to come back, because obviously a lot of volunteers and a lot of resources perhaps don't have the funds or the capacity to restart again. So we really need to think about how we enable people to get not only the diagnosis, but then the support that may follow it. So it's really, really important. Next slide, please. You'll see from this slide, it kind of really highlights that drop in diagnosis rates that we've seen. So the blue line, which is the sort of line at the bottom there, that's the current diagnosis rates, with the green one at the top being where we were in 2019. So you can see, it's kind of sitting at nationally, that 70%, 69 to 70%. And that starts to tail down as we get through 2020, right down to what we see now in 2021. And certainly where I live in Norfolk, we've got significant variations across our places in the area as well. So you might have one area where it's 67% and another area where it's 50%. So there's a huge amount of work to be done in finding out what the barriers to that are and what the enablers are. And we see one of the enablers is getting more people aware of what the symptoms might be, and then feeling more confident and competent in screening and understanding what to do with that. Going back to my situation about people seeing it as a mental health problem, people often don't realise what the best way is to identify the symptoms initially, then to screen, and then to move people through the system to enable them to access a diagnosis. So we hope you feel a bit more confident in that as we get to the end of the session later on. I want you to think about, you know, people that you might be working with or you've come across who may or may not have a diagnosis of dementia, thinking about why it would be important to them within the roles that you work. And we're just going to take a brief moment after the next slide to think about that. And I'd welcome you to put your thoughts into the chat boxes about why you think it's important. Perhaps we can have the next slide up, actually, Rachel, number 11, that'd be great. For you to think about why would it be important. So we've touched on a few issues, but I think there are so many more. And I think what we want you to think about is, why would it benefit people you work with? What would the benefits be? And what difference do you think it would make to them and their family carers should they be able to access the diagnosis? So we'll take 10 minutes there for you to have a think about that. Just take a comfort break. And then we'll come back with thinking about what those benefits might be and how to enable that access to a screening program and diagnosis at a later stage. Thank you.
Thank you. And I will hand back to Zena and Stuart.
Thank you very much. So hello and welcome back, everyone. Some really useful points raised there in the break. I'm not sure every single one will be covered in depth, but I'll do my best to sort of look through some of those, and there'll also be opportunity for questions at the end. Can we move on to the next slide, please? So in trying to think about some of the benefits and that will go along with somebody gaining a diagnosis of dementia, some of this may sort of refer to points raised earlier. I think treatment options was certainly something that was raised as a theme. And there are, as some of you will know, there are medications for some of the dementias which comprise four choices essentially. These medications slow the progression of Alzheimer's disease in the main. They can also be offered to some with a diagnosis of mixed dementia, and some of them to those with a Parkinson's dementia as well. But it's important to point out that treatments that currently exist have been around for a great number of years. They are not curative in any way. Their primary function is to slow the progression of a condition in which there is a deficit of a particular neurotransmitter in the brain. So the benefits can be observed in the short to medium term, but often in the longer term, those benefits will wear off. But one of the reasons I think medication options are so key following a diagnosis is that if there is a means of improving quality of life and extending, if you like, the period in which people can make informed decisions about their future care, then that is a sensible approach, really. I think the need for specialist support and information advice is also key following any diagnosis. At diagnosis, the person with dementia and the family should be offered referral to some sort of dementia support agency, such as Age UK or the Alzheimer's Society. They have an invaluable role to play in providing advice on all sorts of wide-ranging topics, accessing local support groups, advising on undertaking power of attorney, optimizing finances, supporting carers, and a great deal more beside. Others may need referring on to adult social care if they have specific needs in that area, and some may even be referred to animal nurses if they have more enhanced levels of carer support which have been identified. I think it's important that when someone is diagnosed, we recognize that part of that is to promote them feeling more in control of a condition that they can be part of managing and planning ahead. And that planning can include thoughts around looking at their future care, articulating their wishes and their preferences, discussing advanced care planning, discussing wishes about their end of life, and I think it's still quite sad that there's far too many that will have a diagnosis of dementia who will reach a later stage and will not have had those necessary discussions about their end of life planning. And I think that's something that we all have a role in sort of improving, really. I think one of the phrases that might have come up earlier was dementia rarely travels alone. I think it's a lovely phrase. But I think this underlines the fact that there's a strong focus is needed on managing physical conditions, particularly in primary care. Many people with dementia, with a diagnosis of dementia, will have one or more other health conditions. I think the highest is hypertension. So people with dementia, generally about 40% of those will have hypertension, and as I say, often many other conditions as well. A person newly diagnosed, for instance, with vascular dementia, there may be very strong benefits to primary care looking at vascular protection, ensuring blood pressure, diabetes, cholesterol are all managed effectively to reduce the risk of subsequent strokes. I think managing physical health is not exclusive to vascular dementia. I think optimizing physical health to anyone with dementia is important, not least of which to, if nothing else, to reduce the possibility of any subsequent delirium. There's a strong element of health promotion following a diagnosis, which I think memory clinics have a role in. And that very much centers around promoting healthy lifestyles, a focus on living with the diagnosis, being able to access essential services, advice around exercise, alcohol, smoking, and diet are all essential following a diagnosis and beyond. Next slide, please. So those are the benefits, but naturally there are barriers. If there weren't, in a sense, we sort of wouldn't be here, I think. So the barriers are probably many in terms of why we don't reach that stage where more people are diagnosed. I think core to that is probably skills, knowledge, confidence, competence, and the ability to identify a necessary early referral to a memory service of someone who would actually benefit. It's often been the case, and certainly in my experience in 9 years in a memory service, that referrals for many may have come at a point where there would be less benefit than had that person been referred a year or two previously. And it's essential that we have an effective way of screening those who can be referred, who can be diagnosed if that's their wish, and can benefit from an earlier diagnosis. It's a sad situation that so historically many have waited for things that almost hit a crisis before the problem's been identified. I think there's a need probably to be quite proactive in primary care, and practice nurses play a key role in identifying patients who may benefit from a referral. You know, for instance, an elderly patient may come in for an annual health check, may have diabetes and COPD and heart failure. It is useful to suggest a memory assessment at that point in time. I think we can change the narrative in these situations from asking someone if they're worried about their memory to actually saying, do you mind if I check your memory and do a brief memory test? With the person's consent, I think that is a more proactive way of identifying the problem, because asking someone if they're worried about their memory may not pick up every single person who has a memory problem, particularly if insight is not that strong. So it's maybe about changing that focus when people come through primary care. I think some patients may have a view that there's little support available, or that there are no treatments. We all have a role in ensuring that those referred are well informed of what they should expect. I think stigma is still quite significant in patients and their families not reporting symptoms, but alongside that is a lack of awareness. Some may not perceive it as being a problem. We talked about normal aging earlier, and again, thinking of people that I will have assessed in a memory clinic going back, many would ascribe initially their problems to getting older. A natural assumption that I'm forgetting, or I'm not able to find my words so easily because I'm in my 80s. And in some ways, we have to try to dispel some of these myths and ensure that those who would benefit from a referral are actually referred. I think confidentiality is important. We have to consider capacity and consent. And I mean, in some ways, these are quite weighty issues worthy of another presentation. But I think it's important that we take account of the patient's wishes around discussions in line with the Medical Capacity Act. And we only act in the patient's best interests if there is a strong rationale for doing so. Next slide, please. So, having thought about the advantages and the difficulties, what are the opportunities that we're now faced with? I think the reduction in diagnosis rates over the last 18 months has been quite significant, as the slide that Zena put up demonstrated. A massive drop in the number of people diagnosed. And when you balance that against the expected trajectory of people who may have dementia in the next 20 to 30 years, those two things are quite a frightening contrast, really. There was a recent article, I think, in the national press that pointed to something like 50,000 cases being missed during lockdown. And during this time, I mean, memory services have, in a sense, operated a different approach, a more hybrid model of assessing through telephone, assessing through video conferencing, and conducting more limited face-to-face assessments. But alongside that, memory services have also had additional investment to enable an improvement in their diagnosis rates. So we shouldn't be, in a sense, put off by a sense of a possible waiting list. There are strategies in place that continue to improve that. And if a referral is a necessary and beneficial, then that is that is a desirable outcome. I suppose there are those groups who would be at some risk, or some greater risk, really. This might include those with a learning disability difficulty, which was alluded to earlier, and I'll come on to that issue shortly. It might include those who are working age with dementia. It might include those in long-term care, those with a history of alcohol dependency. All of these, in a sense, would benefit from a very close level of screening and looking at the complexities of their individual situations before making a referral. Some of those I'll cover in a moment, though. I guess it's also important to recognise that memory we often see as being the primary initial symptom of someone with dementia. That if someone comes to us with short-term memory problems, for the most part, we suspect that to be the onset of a dementia. But someone of working age, memory symptoms may not be the first thing that you'll see. In those situations, in working age patients, we need to be looking for other changes, which I'll cover shortly. But it's important in those situations to be aware that it's not just memory as a core symptom, and to listen to the concerns of family as well. Now, care home residents, as Zena mentioned earlier, 69% of care home residents either have dementia on admission or develop dementia following their admission into care. I think it's fair to say that although many in residential care may have a diagnosis of dementia, not a large number would actually be offered the medications that I sort of briefly spoke of earlier. The primary role of these medications is in community dwelling patients to try to reduce or slow down the rate of admission into residential care settings. So the medications, although a viable treatment option, are not always the first thing that's thought of when someone is diagnosed with dementia in care. But that's not the only reason that these diagnoses should be encouraged. It helps to ensure that there's an appropriate plan of care, a personalised plan of care for that person based on their specific individual needs. It's necessary to enable staff to be aware of issues in relation to mental capacity. Now, there is a specific tool which can be used to support diagnosing those in residential care, which I'll talk about on the next slide when I'm going to look at some of the cognitive assessment tools. So next slide, please. So an abridged version, there are many, many more. I think probably the important distinction to make when we talk about cognitive assessment tools is that in some ways there are two tools at play here. There are those that are possibly more relevant as a screening tool, so that can be used in primary care to guide and support a potential referral. So in a sense, to highlight something which may be a problem, and along with the collateral history, supported a referral onto diagnosis. And then there are tools which are designed more to assist with the diagnosis, used as a cognitive assessment tool. So I think when we talk about cognitive tools, I think there are those which are more relevant and useful as screening tools, and those which are more beneficial to aid the sort of subsequent diagnosis. In looking at this list, I think the first four would largely be considered to be screening tools. The exception to that would be the mini mental state. Now, the MMSE is probably the oldest of all the tools, 1975, I think. It's been around for an awful long time, originally designed as a sort of bedside assessment tool. It is sometimes used in primary care, I think, and may also be used in some areas by memory services, but I think with much less frequency now. But I think that would largely be considered now as an assessment tool rather than a screening tool. I suppose the last three really, the TYM, the MOCA, and the Diadem would all be considered as tools that are used to assess and support a diagnosis. I think of the first three, the sort of those more useful in primary care, the GP cog and the 6 CIT are probably used more widely because of them being validated in primary care settings, whereas I think the AMT was not. So the GP cog tends to be, certainly in the area that I work in, more favoured. I think it's also important to point out that some of the tools do actually have copyright issues in relation to them. So the mini mental state examination is restricted under copyright from an American company called PAR. And the MOCA, about a year ago, started to introduce training, which I think you had to pay for to be able to access using it. So some of these may actually have restrictions which would limit their use. Probably also, if using any of these tests, it's important to point out that they don't all operate in the same way. In some of these, a high score may lead to a referral. In others, a low score may lead to a referral. So there's no simple formula with which you would sort of operate the same approach to all of them. The TYM, I think that's fairly new to the party. That's been used the last year or two, often by memory services, because it could be used remotely. It's been used over the telephone and through video assessments for some of those referred, particularly in the early stages of lockdown when face-to-face assessments were not being offered. The Diadem is an important tool. It's used by or can be used by GPs to diagnose someone in a care home. So in thinking about that high percentage of people in care who may have dementia and may not have been diagnosed, the Diadem allows a GP to look at avoiding a referral into a memory service by going through essentially a tool which looks at self-care abilities. It looks at the history of the decline in a person. It looks to exclude there's any physical cause, and I think also includes the 6 CIT, which is one of the tools above. So an increasing number, it's important that those people avoid being referred onto a memory service and are diagnosed in primary care by GPs if there appears to be an advanced stage of dementia for someone in a care home. Next slide, please. So what are the possible differential diagnoses? I think first and foremost, it's important to eliminate depression. So depression is an interesting partner, if you like, to dementia. On the one hand, we need to perhaps eliminate the likelihood of a depression before referring somebody straight onto a memory service. If there are changes in someone's attention and motivation and energy and so forth, it's important that we consider the possibility of depression and actually treat that before coming back to reevaluate that person's current abilities. And if there's an improvement, or appears to be an improvement in mood, but there's still suspicion of a cognitive change, then that's a relevant referral. I think it's also worth remembering that those with depression seem, for reasons I'm not entirely familiar with, have an elevated risk of developing dementia. And depression may also accompany dementia in different stages. So in some ways, it's about, I think, eliminating the possibility of a condition that may be either masking a dementia or may actually be the reason for query cognitive changes. Delirium is a particularly high risk in older people. Those already diagnosed with dementia are something like 50% more likely to suffer delirium compared to those without. And I think it was one of the earlier slides, I'm not sure whether I put that up or not, but there's, I suppose, the distinction between delirium and dementia, as most of you will know, is that delirium is largely temporary. It dissipates when treated appropriately, usually within 2 to 6 weeks. Dementia, however, as we've identified, is a progressive neurological condition. So those going into acute settings, those perhaps seen by services in acute hospitals, may be admitted with a delirium, but time needs to be allowed for that delirium to resolve before then rechecking if that person still appears to have some cognitive changes. Normal aging, I think, obviously we covered earlier. Mild cognitive impairment, I think, excuse me, it's important that we are aware of mild cognitive impairment as a condition in and of itself. Often people coming through a memory service when diagnosed with MCI would say to me, I've never heard of that, and that's not unusual. Everyone's heard of dementia. Most people have heard of Alzheimer's and ask you, is there a difference? But many would be unfamiliar with the term mild cognitive impairment. And what distinguishes mild cognitive impairment from dementia is the fact that any changes to functioning and memory at this stage are not significant enough to be considered to be dementia. But of equal importance, they're not considered at that point in time to be progressive. So with an MCI, what might have occurred is a change to someone's abilities in a small way, but no evidence of progression. With the dementia, there would be a trajectory in which there should be able to identify some sense of progression. MCI is an important diagnosis because those who are given this diagnosis have an increased risk of transitioning to dementia over the longer term. There are differing conversion rates depending on which study you read, but by and large, it's agreed that there's an annual conversion rate of something like 10 to 15% of those with MCI to go on to develop dementia. So again, those who've been diagnosed with MCI in primary care, it's important that there are evaluations of their abilities and early re-referral if there are changes noted. Next slide, please. So as we know from one of the earlier slides, learning disability, those with learning disabilities are at an increased risk of developing dementia. But it's often difficult to recognize the symptoms in the same way that you would in someone without a learning difficulty. In this group, it's particularly important then that we have other means of considering what the changes actually are. using a cognitive assessment tool or a cognitive screening tool such as the GP cog may be of quite limited value, particularly if there are issues around literacy and numeracy. So we need a sort of wider perspective on what the issues would be that we'd be thinking of. I think as Zena referred to, it's important to focus on the functioning that the person may have had before the age of 30. That gives us a sort of baseline as to what someone's general abilities were at that point in time, and in a sense the ability to put the tracing paper over the picture to see what the actual changes may be. Those changes may be evident in things like self-care abilities, in personality, in behavior, but also it's of crucial importance to ask those supporting those with a learning difficulty of the differences that they've noticed over time. It's a good time to review this is if someone is coming for an annual learning disability health check, then as with all other patients accessing primary care, to seize opportunities to screen for dementia as a matter of course. It's essential, I think, that we have a model where we are considering dementia as one of those things that we think about when we're reviewing somebody in a primary care setting, that it's uppermost in our thoughts in a way of identifying those who would benefit from being referred. I mean, other conditions may also appear as dementia, but be eminently treatable. So thorough physical screening is always valuable. Which I think provides a perfect segue into my last slide, if I'm not too far wrong. Oh, yes, it does. That's good. I like it when I'm right. So here's a list of the sort of investigations that you might expect to be carried out as a sort of screening, the screening bloods as they're often referred to. Now, we can't go through every single condition that may affect cognition, but there are clearly many physical things that could be identified through some of these screening bloods, which could be affecting someone's concentration and attention. You know, thyroid disorders, metabolic disorders, anemias. There are a long list of physical changes that we can possibly pick up at this stage, and may even avoid an unnecessary referral if there is something eminently treatable. In my view, screening bloods perform two important functions. They help to eliminate if there are treatable causes of a changed presentation. So in a sense, we sometimes used to use the term treatable dementia. I think what we're looking at is treatable causes of cognitive changes. If someone's presentation has changed, then we need to at least eliminate if there are physical reasons for that before referring on. But also, if someone is referred onto a memory service, they help to guide the subsequent treatment options. They're invaluable in forming part of that decision that follows the diagnosis about whether or not somebody will be treated with particular medications. White cell count, I think, is obviously very important. Sometimes a clue that somebody may have an infection, and considering an MSU at that stage is also a good idea. That's quite a lot of information, so I'm now going to pause, take a swift swig of my coffee, and hand back to Zena. You're on mute, Zena.
You're on mute, Zena.
There we are. We're there. Sorry, guys. I was going to say thanks, Stuart, and thanks for handing over. So I was going to say, so to start with, what we did was talk a bit about what's the benefit of the diagnosis, and we've now looked at how we might start that process in terms of some of the screening tools that we might use and the process. So just to kind of tidy that up and kind of finalize that, I just want to make sure that everybody is clear on what the process is. So, for example, someone will present with concerns, or we might actually have an opportunity to identify some concerns. And then what we would do is, with consent, administer one of those brief screening tools, depending on the environment we're in. And I'll touch on that shortly in a moment. Then following that, we would perhaps request a GP appointment for a more thorough assessment if we didn't feel that we were able to do a more thorough assessment within the context of our role. And that would mean perhaps further screening and discussion around what the issues might be. And if someone scores or performs badly on the screening test, then we would do the screening bloods, which would mean that we would try and rule out some of those differential diagnoses. Certainly at that point as well, I would probably also be thinking about whether someone's mood is impacted upon as well. So not just thinking about dementia, but whether they might be depressed, whether they're grieving, whether they've got pain, all those other things that might be contributing to their current presentation. At the end of, once the blood results come back, if there's anything that's modifiable or treatable in there, we would manage that first. Then we would go back to the start of the process again to then see whether that's rectified the problem or whether that problem remains. And then if the case is that that person's still experiencing some issues with cognitive impairment, we would then refer them through to the appropriate resource. Now, for younger people, that might be neurology. For people with learning disability, that may be learning disability services. It may be mental health memory assessment services. And in some areas, primary care are doing some of the assessments themselves. So depending on your local area will depend on what the resource is. And then that person will be more thoroughly assessed. I certainly see in the chat box there's conversations about screening tools, and that's when more comprehensive assessment tools such as the ACE will be used to really, really dig deep into terms of where that person might be experiencing difficulties, and then that will help the subsequent diagnosis. Now, we may well in some areas it may be requested that someone has an ECG if they've got some issues with the heart that might be supporting the presentation. However, often the ECG is requested as a monitor to see whether someone can have the medication, because if people have a low pulse or heart conditions, they may not be appropriate for dementia medication. So that's often the reason why the ECG is asked for. So it doesn't always need to be prior to that referral onwards, it's often afterwards if that person is appropriate for treatment. So I think the other thing to understand is often that when someone is referred through to those memory assessment services, other than signposting to the resources that Stuart was talking about earlier, they will often be directly discharged back to the care of primary care, unless there's some ongoing management in terms of managing medication. And I think that's really important to highlight, because I think in some cases I've spoken to colleagues who've got this misconception that once they're referred to memory assessment services, that mental health are supporting that person for the longer term, and that's not the case. In fact, there are very few people who receive that ongoing support in memory assessment services, other than for that initial medication titration. Or their needs are seen are very complex and they go through the community mental health team. So hence the importance of kind of all of us pulling together and making every contact count. So understanding a little bit more about that process is thinking about, well, where would we have the opportunity to do this more often? So if we can think about opportunities where it might be easier to identify some screening. If we could have the next slide, please, Rachel. One of the places that I think is really important is thinking about long-term condition reviews in primary care, for example, and we kind of touched on that briefly, but thinking about that in the broader concept, because comorbidity is, as I say, more than two conditions, and multimorbidity is not just about health, but it's also about social implications as well, and lifestyle behaviours that can influence in people's health and well-being. Now, for many of us, we might be coming into contact with someone perhaps in an annual review in the surgery, for example, around heart failure or blood pressure. Now, we know that those patients might be at higher risk. Often in those annual QOF reviews, the questions that asked is in response to kind of considering memory or dementia as a possibility is, are you worried about your memory? Now, most people at that point will go, no. And we've ticked that box on the review. I think there's some real opportunities there to think about using the mini cog in that situation, which is a very brief screening tool. It's 3 questions, which doesn't mean to say you're going to go with a full assessment at that point, but it's about starting to screen people in and out of a longer process. So it will ask people to recall 3 words and do the clock face, and it can be administered within 2 or 3 minutes. And it will enable people to identify where they've got problems. Now, rather than asking the memory question, if we offer that to people openly, I'm not suggesting that we do population screening, but for those people who might be considered higher risk, that might give people an opportunity to be picked up earlier and to then go through that process. And of course, if we're looking at people with comorbid conditions, if they have some cognitive impairment, actually that might impact on how they can manage both their treatment regimes and their compliance with anything that we suggest is appropriate in lifestyle management. An example of which is diabetes. You know, if you've got cognitive impairment and you're insulin dependent diabetes, you know, you may forget to administer your insulin at the right time. You may lose some dexterity, so maybe not able to draw up the insulin, all of those things. So the cognitive impairment impacts directly on the ability to manage diabetes. So I think those are touch points where we have opportunities as well. I think also community nurses, therapists, staff, you know, are often coming into contact with people in their own homes and have a very, very good view of what's going on at home, because of people presenting in a GP practice will present very differently to someone in their own home, and you can pick up all those visual cues and clues about their environment, maybe their weight, you know, maybe they're not as well kept as they used to be, they may be losing weight because of the fact they can't prepare a meal. All of those things might be picked up by staff who are seeing people for other reasons, but can then think about, well, is there something else going on? Is there an opportunity to do some screening here to see if there is a possible dementia or something else that's treatable going on in the background? And I think that's often quite difficult these days, where our roles are often very task focused and we're expected to do a job within a certain space of time. But I think it's about that kind of what are the benefits to the patient, and we've mentioned those already, but also to the system, because if we know that someone's got dementia and we can identify that earlier, we can support them to manage their conditions more effectively and prevent them going into crisis. Next slide, please, Rachel. So Stuart mentioned, you know, one of the biggest comorbid conditions is hypertension, but you will also get people who are presenting in a lot of pain with painful conditions such as arthritis and rheumatism. They may be because of aging and frailty. They're more likely to be in the higher risk groups. And like we said, depression and dementia are often very, very, very closely linked in terms of some of the symptoms. They can be very, very difficult to unpick sometimes. And just because you have one, it doesn't mean you can't have the other. But again, we do tend to look at these very singular disease processes rather than that holistic person-centered assessment to kind of unpick those elements to see what's going on. And I think, you know, we need to establish that what often happens is, and the one of the drawbacks of a dementia diagnosis can sometimes be what we call diagnostic overshadowing, where when someone gets a diagnosis of dementia, everything that happened to them subsequently is attributed to the dementia. So for example, I met a lady in a care home who had gone in because she was quite frail, she was quite poorly, she had vascular dementia, but quite early stages of vascular dementia. And the care staff were really worried about her. So in the first few weeks that she was there, her appetite significantly waned, she'd lost a lot of weight, she wasn't sleeping, her head was down, you know, she really was in quite a poor way, you know, she was really, really, and they were distressed seeing her like that. So they'd spoken to the GP who said, oh, it'll just be a progression of a vascular dementia. Well, I spoke to this lady, I managed to encourage her to come through to her bedroom so we could talk privately. Now, instantly on mobilization, you could see that she was in pain. She was quite uncomfortable. She walked with a frame and she was quite stiff. So that was noted. And when we got to the room, her head went down and I asked her how she felt. I said, do you feel lonely? Are you sad? And she burst into tears and said yes. So yes, this lady did have a vascular dementia, but this lady was also in pain. So we managed to get the right pain relief prescribed to her, which in itself doesn't help with mood or mental well-being. But also it was recognised that this lady was experiencing some symptoms of depression. And this is someone who had been very active prior to going into residential care. She'd had quite a social life. She was then socially isolated and lost her independence. So unsurprisingly, she was feeling low in mood. So we addressed that. We actually prescribed this lady some mirtazapine, which helped with her appetite. She started to improve. I saw her 6 weeks later and she had lipstick on and she'd struck up a few friendships with people within the care home. Now, I think that's just a nice example of just trying to think about the bigger picture for these people as well, you know, who are living with dementia or who may get a diagnosis of dementia, and thinking about those opportunities to not only diagnose the dementia, but pick up other things that might be impacting on their health and well-being. Next slide, please, Rachel. So a lot of the comorbid conditions you will see here are ones that we do have contact with people for annual reviews or regular reviews for other conditions. So, you know, COPD, heart failure, hypertension, we tend to pull people in for an annual review. And as I said, you know, the frustrating thing is that we'll often pull them in for 4 different reviews as opposed to one really coherent review where we can look at everything in totality. So I think, again, for those of you who work in primary care, if you can see any real opportunities to kind of pull some of those assessments together, I think it's really, really important to do so. And actually asking beyond the questions that are on the screen on system 1 or whichever system you're using, and thinking a little bit more broadly about some of the things that might be impacting on that person. And I've spoken to a lot of healthcare assistants and practice nurse staff who say, actually, I've known this gentleman for the last 6 years. I've done their annual reviews. I do their, you know, their medication reviews. I can see something's different. I can't quite put my finger on it. But if I was to ask them if they're having problems with their memory, they'd probably say no. But when I've administered mini cog, it has highlighted that there's been an issue, and I've been able to get them to come back to the practice for further assessment. So I think, again, you know, whether you be in the community or primary care, there are those points where we can make every contact count if we've got concerns about whether someone's developing dementia. Next slide, please, Rachel. One of the other, so these are some of the other things that people might be experiencing and present with. And again, thinking about the impact of what cognitive impairment will have with some of these conditions. Urinary incontinence, particularly if someone presents with incontinence, often we start to think about the very medicalized elements of incontinence, but is it more about functional incontinence? Is it the fact that people can't get to the toilet in time? Is it that they can't find a toilet in time because they've forgotten where things are? Could that be an early indication that someone's experiencing difficulties? Weight loss can be a real indication that there might be problems when you think about it, because if you forget how to prepare a meal, or you don't feel confident in going out shopping anymore, all of those things, or you can't manage your money, your confidence goes, all of those things are going to impact on your weight and your ability to maintain a safe weight and eat well. So those are things that are things to be monitoring for, but also thinking about some of the preventative work that we can do as well, in terms of thinking about urinary tract infections. And of course, if we manage incontinence better, we reduce the risk of that. And if we reduce the risk of infections, we reduce the risk of delirium, which, as Stuart's already said, is very, very prevalent in people with dementia for multiple reasons. If you are cognitively impaired and someone forgets to give you your hearing aids or your glasses, that can be incredibly difficult as well. So if you do start to do some assessments with people, you know, be fair, make sure that they've got the tools that they need. I've actually seen a lady diagnosed with dementia in an acute hospital because she was deaf. So although she thought she was responding appropriately to the questions, she wasn't. So from that perspective, you know, do think more broadly about the right environment as well if you are going to undertake some of these assessments, and think about whether someone's in pain, because pain is a huge feature for older people and often very badly managed. I think I'd love to ban PRN medication of paracetamol in care homes, for example, because often care home staff are not confident in giving PRN medication. And I've often trialed PRN paracetamol in patients, which is far more effective than antipsychotics, things like that. So, you know, do think about what else might be going on for those people who do get diagnosed. If we could go on again, please, Rachel. So we've mentioned this a lot. in terms of what are the impacts of dementia and comorbidity. So we've got the issues with quality of life, we've got the costs of the system, because we become very, very reactive as opposed to proactive. So if we know, we can plan, we can think about the future, we can support people to think about decisions and what they might want for their future care. We can actually think about whether there are goals of care that we set differently. Do we start to think about the fact that actually the treatment regimes are actually really quite intense and they're not as a benefit? So we talk about that quality quantity kind of conversation. So again, having those really frank and open conversations, and the earlier that someone gets a diagnosis, the earlier it enables us to do that, so that they feel fully informed to be able to have their voice heard. And of course, we do know that a huge amount of people with dementia end up in hospital. The difficulty is if they end up in hospital, they are more likely to experience more ill health and are more likely to be discharged to care homes. So obviously, if we can pick these people up earlier, identify them, give them the support and care planning that they need, the outcomes can be significantly improved. Next slide, please, Rachel. The Diagnosing Advanced Dementia in Care Homes diadem tool is another really positive opportunity to improve diagnosis rates and identification. So GPs can do it, but actually we can have very skilled clinicians who are not GPs do it, because the process is very clear, it's very discreet. So most advanced nurse practitioners, community matrons, therapists who are skilled in dementia assessment could very easily do this assessment. And it's about, again, thinking very laterally about the impact on that person, being able to inform the family, inform the care staff, and one hopes that in time what it will do is inform decisions at people's end of life to prevent them going into hospital unnecessary when treatment may be futile. And certainly the care home staff that I've been doing this work with in some of the care homes in Norwich have said actually it's really, really helpful for them in terms of planning their training needs, in planning their staffing levels, lots of things that can really have a positive impact by knowing what the person's needs are and having a better understanding of those in a holistic way. I think the other opportunity, and we touched on it briefly, is with patients who've been previously diagnosed with mild cognitive impairment. So because we know that some of those people do translate into a developing dementia, giving people the opportunity maybe 9 to 12 months after they've had that initial assessment and got that diagnosis of mild cognitive impairment may mean that we can get people to be assessed more quickly should their situation deteriorate and they be one of the third of the patients that might go on to develop a dementia. So there's lots of opportunities, but I guess the essence of today is about thinking about making those contacts count and what you can do with your own practice, both in terms of the people that are currently within your caseloads, but perhaps prospectively thinking about how you might be able to incorporate some of these opportunities going forward. Next slide, please, Rachel. So when it comes to thinking about annual reviews, there are some guidance there from NHS England that talks about best practice. So again, making sure that we don't just make these tick box exercises, that we make them count and we use them as an opportunity to signpost people to the correct resources, identify when there are problems occurring, and certainly thinking about the impact on family carers, for example, when someone is caring for someone with dementia and multiple comorbidities. Next slide, please, Rachel. So these will be available to you. And of course, going back to that first point that we had, or the first couple of slides, is dementia is a neurodegenerative condition. So everybody who is diagnosed dementia will die with dementia, even if it isn't the cause of their death. So thinking about that much more prospective advanced care planning, so not waiting until the last year of their lives, thinking about if someone gets a diagnosis, when is the best opportunity for them to be thinking about what their future care plans or future wishes might be. And again, there's some guidance there from NHS England about thinking about advanced care planning for people with dementia. And it may just be introducing people to the conversation. And again, because of the system we've got at the moment with people being passed back to GPs very quickly after diagnosis, if they don't present again for another 2 or 3 years, we might have missed the opportunity to enable them to have those conversations. So I think it's about understanding where the system fits, what our roles are, and where we can actually enable people to have a voice and feel heard within the context of their future care needs. I think we're there, aren't we? So yeah, when you do diagnose someone with dementia or you facilitate it, do make sure it's coded appropriately on their notes, because obviously if someone is in the community then goes into hospital or vice versa, if that diagnosis is known, it informs people about the patient's needs, their person's needs in the context of the care environment they are. And I think for me that the real mantra is just make every contact count. You know, don't think that someone else will do it. You know, you know the patient, you have the skills, you have the abilities. Hopefully we've given you some of the tools that might be able to enable you to start that process off, and you really can make a difference for people with dementia at a very early opportunity if you feel more confident and competent in using those kind of assessment frameworks. So thank you very much for listening, and I'm sure there will be some questions to be